Hey, thank you all so very much for joining us for this meeting of the International Noma Network. I'm extremely excited today to introduce both of our speakers. We have Petra Raschkewitz, who is going to be speaking with us from Hilfsaktion Noma, and we have Dr. Yuka Makino from the WHO Africa region. So thank you very much to both of you for coming and agreeing to speak with us today. Our first speaker, Petra, obtained her PhD in art history and quickly decided to pursue a career she felt would be more meaningful to herself and others. She entered the world of international cooperation and project management via the Department of International Media Development of the German public service broadcast Deutsche Welle, where she developed and managed various large-scale projects on press freedom and free speech all over Eastern Europe. Looking for new challenges, Petra got recruited by her former boss, Mr. Matthias Winkler, as a project manager for the Germany-based NGO Hilfsaktion Noma in 2019. She manages the organization's country programs and cooperations with the Ministries of Health in Guinea-Bissau, Senegal, and hopefully soon to come Mozambique, as well as scientific research projects on Noma that are implemented or co-funded by HAN. For her presentation today, Petra will give an insight into the practical work of Hilfsaktion Noma in the areas of prevention, therapy, and social reintegration of Noma patients. Petra, thank you again so very much for your agreeing to speak with us today.
Well, thank you very much for having me, John. And hello, everybody. So I will try to show my screen, fingers crossed. Does this work for you?
Yes, thank you.
Perfect. So, of course, I'm not going to get the door. Hi, everyone. My name is Petra. And as John already told you, I'm a project manager here at Hilfsaktion Noma, which roughly translates as Action Aid Noma. And I will also refer to it as HAN because it's just shorter and people can actually pronounce it. We're a nonprofit and non-governmental organization based here in Germany. And obviously that's not me in the picture, but I think that slide actually shows quite well our philosophy. So at Hilfsaktion Noma, we try not to shine the spotlight so much on ourselves or on our organization, but we have been active quite a bit, and we really try to shine the spotlight onto Noma patients and their needs and try to meet them. So while in recent webinars, you probably have heard quite a lot about scientific research and also advocacy and political strategy making. And I think Yuka will also tell us a bit more about, regional strategizing. I think my presentation is going to be much more on the practical aspects of fighting Noma and grassroots work, because that's basically how we identify ourselves with. Why does this not? Okay. So here's a little bit of history to run through. Don't worry, I'm going to gallop. But I thought it's actually quite interesting to see how Han actually evolved and how it developed over the past almost 3 decades. So the picture shows our founder, Mrs. Ute Winkler-Sturmpf, and she was a high school teacher, just regular person, and she watched the TV show Noma and was deeply moved and decided to do whatever she could within her own personal options, and just collected some money to bring children to Germany from Niger to obtain surgery here. And then she got more and more involved, and she booked herself a flight to Niger and decided to take a look for herself. Hopped onto the next plane and realized that just evacuating children is not going to be a very sustainable and not very long-lasting solution to the problem of Noma, which basically is a poverty issue. So she decided that things should start in a very much more holistic way. So she decided to actually start working within the Noma belt itself. And then you can see how things really took off. So she reached an understanding with the government of Niger between 1996 and 2001. Han opened a couple of children's houses where children affected by Noma are basically centralized before they can actually be operated on. Then we opened the clinic La Maja, which is basically really up to Western standards. We support the vaccination program in Berlin-Conny since 2006. So obviously there's no vaccination against Noma, but there are a couple of major risk factors that can be fought against by immunization programs like measles, polio, tuberculosis, etc. We opened another children's house in Agadez. Then in 2008, Han was invited by the government of Guinea-Bissau, a very small country in Western Africa, who realized it also has Noma cases apparent in the streets. And we were invited to actually start the fight against Noma in their country as well. So 2012 was the opening of the Noma clinic in Bissau, in the capital of Guinea-Bissau. Then we also realized that Noma is so closely related also to a lack of adequate food, and food and famine is such a big problem. So there's also the establishment of an alimentation clinic that happened. And we support those clinics by food deliveries, etc. In 2022, we opened a reintegration center in Bissau. I'm going to talk about that a little bit later. And our last strike was the opening of a new Noma center in Abuja. We paid basically for the construction, and our partner organization, NANI, is going to run the daily clinic business there. So our current focus countries, I made this not so beautiful map, but I think it's quite good to realize that Han is either directly implementing or working in bilateral cooperation with the ministries of health, or within supporting the WHO Regional Noma Control Program. I'm not going to tell you too much about that because that's really Yuka's domain of excellence, obviously. But I think it can be seen that we're active in quite a lot of places in one capacity or the other, all over Africa, basically. And our direct implementation or bilateral cooperation takes place at the moment in Senegal and Guinea-Bissau, Niger and Nigeria. But we also had some pilot projects going on in Ethiopia and Mozambique. And we are currently in the, we're trying to establish something more and long-lasting there. So these are basically the four cornerstones of our work. So as I told you before, we basically started off with treatment. So we offered surgery, and it became very soon apparent that this still is an important step of our work, but it's not the only one. If you want to take care of Noma patients, there's a lot more involved. And one of our main cornerstones actually is prevention. I would say we do much more in the preventive area than we do in the actual therapy or follow-up of Noma patients, because basically no therapy, no treatment, no surgery result can be as good as not developing the disease in the first thought. So that's why we put a lot of energy and also finances into preventive work. And then social reintegration. When you take care of a Noma patient, it means basically that you have to accept to take over that responsibility for probably a couple of decades. So treatment cannot stop at the surgery, at the operating theater. It has to be beyond, because fighting Noma is basically trying to break the vicious cycle of poverty. And if you want to break the cycle of poverty, you have to give people a real chance in obtaining a life, which also means, education, professionalization, probably also support with mental and physical health issues that come from surviving Noma. So there's a lot, and the disease is still covered with a lot of stigmatization. So you also have to help these people to get back into their society. And there's a lot of communication involved. I'm going to talk a little bit more about each of these points. So that is just like the introduction. Last but not least, and it's become more and more of an issue for us in the later years now, is building capacities, because we realized that, well, every humanitarian work, I think, should always be help to help yourself. So creating expertise in the country most affected by Noma is probably the most sustainable solution. That at some point it might not be necessary to bring in international experts. There's a lot of talent on the ground in Africa, but taking care of Noma patients means a lot of skills. For example, microvascular surgery. That's nothing that you can learn in a year. So there has to be a long-lasting training strategy. So we try to establish that at the moment. So when we talk about prevention of Noma, you can see we do quite a lot. So we have some areas that we cover by ourselves. Like we do a lot of sensibilization activities where we go to marketplaces, to health centers, to schools, to basically whoever wants to have us gets informed about what this disease is, how can you recognize it, that it's not related to witchery, to witchcraft, that it's nothing to be afraid of, that it's not contagious, and that you can actually prevent it and how. And we also deliver alimentation supplies to specific vulnerable groups like orphanages, mother and child centers in the regions. Alimentation costs have really risen in the past couple of years in Western Africa. So a lot of communities just cannot give enough food to poor families. So that has become quite an expensive, but also very important part of our work. We do media campaigns regularly where we tell people about our work and where they can contact us, or our local teams, it's better to say, if they know about a Noma patient and how the family can reach us. And we do regular field missions off into the various regions where that's possible. There are countries like Niger where traveling is quite unsafe, and we cannot demand that from our employees. But in countries like Senegal or in Guinea-Bissau, for example, we actively go into villages, search for patients, and also offer free medical and dental consultations and screenings, because that's basically the easiest way to detect Noma patients if you just look into the mouth. So we do that. We check a lot of mouths. Then we have a couple of activities we do together or in cooperation with the Ministries of Health. So one thing is support for the Krenis. I don't know if everyone knows what a Kreni is. So that's basically the emergency alimentation services of some state-run pediatric departments. So if you have severely and extremely malnourished children, especially toddlers and babies, they get referred to the Kreni systems. And there are usually a couple of them. And for example, in Guinea-Bissau, but also in Niger, we support the Krenis with all the necessary food items and also medical supplies like bandages, whatever they need. Then we also support vaccine programs. A couple of times I had emails asking, why do you say that you support the vaccination programs? The vaccination charges are free. And that's true. WHO takes care of it, or UNICEF. But people forget that nothing is ever easy in Africa. So you need supplies to actually get the vaccination from A to B. You need gas, you need service personnel, you need all the supplies that, like syringes, etc. So we provide that. And we do a lot of trainings. Usually the ministries of health do the trainings for the like the formal medical staff members of hospitals. They're usually put into their professional training programs. But we take over those health workers that are not within the official healthcare services. So like midwives, community health workers. And we actually have great results because these community health workers, we use a training program developed by WHO. And these health workers really work as multiplicators. So they go back into their communities, they inform the people about Noma, what they have learned. And we had quite a couple of patients that were referred to us because a community health worker had been in a village and detected a Noma child. So that's good news. So treatment. When I first started working for Noma, it's quite embarrassing to say, but I always had the misconception that, maybe they need 1 or 2 surgeries and then they're done. But of course, it's not the case. So usually when a child has survived Noma, often the mutilations are so severe that they will need about 8 to 10 surgeries in the run of their lives. And by the end of 2023, Han has facilitated 5,208 surgeries. So that's quite a number. Of course, not as many patients. Like I said, each patient needs several surgeries. So you can do the math. But treatment does not only concentrate on surgery. there's a lot more involved. So we also offer medical pre and post surgery care. We offer dental treatments because a lot of times the teeth are just out of control after Noma. We do a lot of follow-up care for our patients. We also take care of HIV infections if they should be an issue for the patient. We offer physiotherapy and logopedic therapy to regain functionality. And we also offer psychological support in order to give the patients a chance to cope with their trauma once they're in an age where they can actually talk about it. And as Elise will, of course, know, we also developed with her immeasurable help a customized patient database that includes a quality of life tool, because we realized, you know, when you do surgery on a patient, it's always walking a fine line. You know, you can definitely agree on the basics, like you want to regain functionality for the patient. He or she should be able to talk again or to drink and eat. But then it's getting slightly more complicated because you also want to get like a certain aesthetic result at the end. But then you have to find the equilibrium, is that how you say it? The balance between what you think is beautiful might not be what people consider as beautiful in their local communities. And sometimes the results might not, you know, weigh out the pain of another surgery if the patient is already happy with the way they are looking at that moment. So it's always a discussion between patient and doctors. And we thought that a quality of life tool might actually enhance that discussion and give the patient a moment of bringing himself or herself into this discussion. And I think it's also quite valuable to have data on quality of life before and after treatment, because it's always so hard to quantify anything about Noma. We have no idea how many cases there are. And it's always so difficult to compete with these large diseases like malaria or tuberculosis. You know, Noma is never going to reach those case numbers. But I think the outcome of that disease is so terrible. And if you can actually make that palpable, even in statistics where usually numbers count, that's quite a bit. So social reintegration, that's also a major part of our work. We offer preschool and school visits to all our patients. We give them the opportunity, if they want to also go to college or to university, if so desired. We do professional training with them. We actually insist on it. In the beginning, they were all like, oh, just give me a piece of land. But yeah, we were able to convince them that, you know, a little cashew plantation might be a nice backup, but they should also try to learn something that they feel passionate about and where they think that they can make a living for themselves. So we do that. We do regular follow-up visits to the families and the communities in order to smoothen the path back into their respective society and community. And we do offer supervised residential, like, how do you say that? It's like young adults can live there if the families live too remote or if the families won't take them back, which sometimes happens. And they can live there, they're supervised, they get support, and they can do their professional training. And we take care that they are slowly adjusted to living a life for themselves. And I think that's extremely rewarding. And you can see that a lot of these patients really want also to give back. You know, always to be on the receiving end is never really the nice end of the stick. And so, for example, here on that slide on the top, you see Juliana. She's one of our patients from Guinea-Bissau. And she, I think 2 years ago, she made her diploma with distinction in primary school teaching and had standing ovations from her co-students. And now she's working as a teacher at one of Han's children's houses. And I think it's great that she also wants to give back to other patients and give them a good start to life. And last but not least, capacity building. So in the beginning, there was a lot of involvement of international surgeons who were invited to our focus countries, did the missions, left. But Han really benefited from the fact that over the years, we were able to train extremely talented local teams. And during the COVID-19 pandemic, for example, Han really benefited from the fact that we have these specialists on the ground and they could still perform operations and treatments in a time when international missions were not possible. So yeah, that's really something we feel passionate about, not to just bring in expertise, but to create expertise and to help these people help themselves. And so at the moment, we plan to establish a long-lasting training program for Noma surgery at the centers in Niger and Nigeria. And we also wish to encourage young women to stand their ground and enhance their own capacities. Here, for example, is Leila, who is working as an anesthesiologist in Niger, where we also have a young aspiring female surgeon. So we think that's something we would like to see more in the future. So thank you very much for your attention. And I'll be happy to answer questions if I can.
Thank you very much, Petra. Yes, please do feel free to ask questions. And if you would prefer not to ask them audibly, please do also feel free to put them in the chat and we can read them aloud. Maisa, it looks like you might like to ask a question. I believe you're muted. Oh, sure.
Yeah. Hi. First of all, thank you so much for this magnificent work. I'm pretty new in the Noma network, and it's just like impressive, really. So congratulations on that. And I wanted to ask you two things regarding first the prevention program, regarding especially early diagnosis. Have you identified a critical point where Noma patients were highly lost to be for this progression? And do you have also a capacity building for dentist or midwife for early detection? Also, I was really interested and, as I said, impressed for using the quality of life, because actually this is where I'm also part of my work. quality of life like measurements. Do you know which tool you have used for this? And like, are you intending to do more work on this area? Of course, the priority is before the treatment and after the treatment to monitor the outcomes of patients. But for example, as oral health related quality of life, there are mainly these 4 dimensions, like pain or psychosocial impact, or for example, function, as you've mentioned. And these things are important to capture, to know, like, the Noma people, what are they are suffering mainly from, or as you also mentioned, the orofacial appearance. Yeah, so I have these 2 questions regarding the early detection and the tool for and the progression for work regarding the health-related quality of life. And if you have both oral health and health, general health-related quality of life, or you're focusing on a specific domain. Thank you.
Okay. First of all, thank you so much for your questions, Raisa, and welcome to the bunch of Noma peeps. It's always great to have new faces. And so exciting to hear that you're also doing your work in quality of life. Let me see if I can respond to your questions. So the first question was on our preventive work. And you asked if, like, what's the timeline basically? Until when could
specifically about early detection, if there is like a special activities regarding early detection, and if you have identified at what stage the Noma patient were lost to the, like, it has this high fatality rate, at which stage those patients are completely, like, you cannot, let's say, unfortunately, save them anymore. Yeah.
So we do a lot. I would say about 50% of our information activities circle around how fast this disease is actually evolving. So there are different measurements of the different stages of Noma. But I would say that I'm safe by saying that if you have not received any antibiotics or help during the first 2 weeks, you're probably in the 3rd stage, where at least the mutilations will not be reversible. So we really talk a lot about how you could identify Noma, because sometimes it can be tricky to make a difference between just gingivitis or if it's an early stage of Noma. And I think a lot of parents, they care about their kids, but it's a toddler who cries a lot when the teeth are coming out. So at first it's nothing that they worry about. But then it suddenly is. And then it's really crucial to find adequate help, like, fast. So we teach a lot about how to identify, and even if they're not sure, to send us, we like in Guinea-Bissau, for example, we have a WhatsApp group, and all the community health workers can send a picture to our doctor at the Noma clinic if they're not sure if that's a Noma case, and he can say, yeah, definitely, maybe, probably not. And if it's a maybe, they get to send the patients to Bissau, we reimburse them, and get the kid checked up. So it should happen fast. And it actually works, like in Guinea-Bissau, which is a small country, so there's not so much population to cover, like in Nigeria, for example, and not so much ground as in Niger. We see that the kids we get to see with Noma are usually in the very first stages, 1 or 2. So we can often help without even having to operate on them. So that's a good result. For your second question, Elise might also be able to say something about that. So we went through all the existing quality of life tools that are out there and realized that we would have to do something ourselves because it just did not depict the data that we wanted to ask. Like you said, it's either how your functioning works or if you're happy or not so happy about your looks. And that's not really, scratching the surface. We wanted to have some data on both. We also wanted to bring in the trauma of stigmatization. Have they been bullied? Did they feel integrated? Did they feel insecure about themselves? Have they been hidden, or did they feel like not being part of their society anymore? So we just had to create something ourselves.
Thank you. I have also a couple of things, but I think I will leave room for the other colleagues.
Yeah, and feel free to contact me via email. You can find my email in the list.
So
Perfect.
I do see that we have a raised hand, but first there was a question in the chat, which I'll read aloud from Jana. Could you please outline what you consider to be the most high impact activities for combating stigma among patients and in communities? Our group would like to add anti-stigma programming for our podoconiosis program, which is non-filarial elephantitis. But she says that they have a small budget.
I guess one would have to ask our patients that. So we try to tackle the problem on different levels. So we do a lot of activities where we basically just talk to, and I don't think you need very much money to do that if you have some sort of infrastructure, like if you have people on the ground who speak the local languages, who have a relation of trust within these communities. Like, I would not consider myself in the position to go to the villages and talk to them in Portuguese, and they would believe me that this is not witchcraft, for example. I think it has to be someone on the ground who is rooted in these communities and who has a certain standing, and they can convince people that this is a disease and that this is a patient and not a wrongdoer, nobody who broke a taboo. So that's basically what you need.
Terrific. And I did see that someone had their hand raised earlier. Okariki, would you like to ask your question? If not, that's okay. And then before we move to Dr. Yuka Makino's presentation, were there any final thoughts or questions that anyone would like to pose to Petra? It's amazing to hear about the work that you and your organization are doing. So thank you very, very much for sharing that with us all this morning or this afternoon or evening, depending on where you are.
Thank you so much for having me. And Maisa, I'm going to leave my email address in the chat box, and then you can send me whatever you have on quality of life.
Thank you again, Petra. I would like to introduce our next speaker today. Dr. Yuka Makino has been a technical officer for oral health at the WHO Regional Office for Africa since August 2019. Her main responsibilities are to implement the global and regional strategy on oral health and the regional Noma control program through supporting member states to develop and implement the National Oral Health Policy Action Plan, and building capacity of the focal points of oral health at the Ministry of Health to accelerate oral health agendas. Dr. Makino holds a PhD in preventative dentistry, a Master's of Science in Public Health with a focus on health promotion, and a Doctor of Dental Surgery. Dr. Makino, thank you very much for being with us this morning as well. I look so forward to your presentation.
Thank you very much for inviting me to this very interesting, Noma Network. And also, I also would like to congratulate Elise and John, and then the other colleague to, organizing this, important network. So from my side, what I will try to talk about, I think today I have a 3 topics. First topic is, of course, what I understand is, today's participants, all of you familiar with Noma. Therefore, first point background, I will, quickly run through. Then after that, I will talk about regional Noma control program. And then finally, I also try to talk about the integration Noma into NTD, and then next step. So I hope you can see my screen. Anyway, so background Noma. So I think all of you know about this background. Therefore, I will not lead through all the information. And also, maybe after finishing this presentation, maybe I can also share this slide. Anyway, so some of you also mentioning about the existence of the global map in the chat box. This group geographical distribution, as you know, that the Swiss tropical medicine team actually conducted the systematic review on disease burden on Noma. Then actually this one showed that geographical distribution. And then as you see that mostly people think that Noma is endemic in the African region, but as you know that of course true burden is not clear yet, but at the same time you can see some of the cases outside of Africa as well. And then especially during the last decade, based on that available review document, Noma cases were reported from 23 countries. Anyway, so as mentioned that one of the issue in Noma community is actually that the data, like a stubborn data, and then we are not so data is strong enough in order to even estimate the disease burden. Therefore, as you know that the most cited data, for example, global prevalence or incidence or mortality is actually coming from 1998 WHO global estimation, such as prevalence 770,000 case, and the incidence is actually 140,000 new cases per year, and also mortality is actually 70 to 90%. That situation also show that the Noma, we don't have a much good quality data. Anyway, so as you know that, of course, as mentioned that we don't have a much, great data, enough, quality data. Therefore, we also face some substantial knowledge gap. Even we have a, data, but we still some substantial knowledge gap. But at the same time, it is also reported related to risk factor. As you see, as like a children, chronic malnutrition and comorbidity, and then lack of access to the quality healthcare service, and also poor oral hygiene, and also low socioeconomic status of the family. And then one of the also issue is that compared with other NTD, Noma, we do not have no point of care diagnosis test available. Therefore, the Noma diagnosis is basically established clinically, and then the criteria is actually different between the clinical stage. As you see that, we have a warning stage is actually simple gingivitis, but stage 1 and then stage 2. Until stage 2 is actually reversible, but after stage 3 is actually irreversible, as you see. And in terms of the, somebody's comments in the chat box, according to the information that, stage 3, the ganglion stage is actually high mortality, high case fatality situation. But what I also would like to emphasize is, of course, the Noma is actually rapid progress. However, if we can identify early, Noma is be actually, treated. Anyway, so from now on, I'd like to talk about key milestone of the regional Noma control program. So a bit, this slide is wordy, but I just would like to change the color, depend on the category, such as blue is leadership, and then green is actually country support, and then the yellow is a technical product, such as the regional Noma control program in WHO African region was actually started in 2001. And then since 2013, I mean, as Petra from Hilfsaktion already presented before my presentation, but at the same time, today, the project director, program director from the Hilfsaktion Noma EV, Mr. Mattis Winkler also joined us. Anyway, so from 2013, we received the financial contribution by the Hilfsaktion Noma, and then we continue the regional Noma control program. And then in terms of the leadership, as you know that we have a regional oral health strategy in African region. And then the global level, we had a, WHO resolution. That is actually the WHO member states. We have 194 member states. By the way, 194 member states actually, request WHO to consider the integration of Noma into NTD. But anyway, so this regional oral health strategy also include Noma issue. And then in terms of the technical, support of products, we actually provide several, technical guidance development, such as, my predecessor, Dr. Benoit Baren actually, led to developing the promoting oral health in Africa. Then after that, he also led to develop the information brochure for Noma. That information brochure actually included the, clinical criteria from the, warning stage and then the stage 1 to 5. And then we also developed the step-by-step guidance, action plan for Noma prevention and control, which can support, Noma affected country to develop the action plan for Noma at the country level. And then we also developed the online course on Noma, in collaboration with various, stakeholder who joined today's, meeting. By the way, we developed the, Noma course in the open WHO, that is a free online course. And then we also developed the Skin NTD appli. So that is an appli which integrated to not only Noma, but also other Skin NTD. And you can download from your phone. And then this information would be, helpful for training of the primary care worker or community health worker. But at the same time, that appli also help the community or primary care worker in case they found some of the skin disease. And then based on that information, they can also, conduct a diagnosis. And then we also, collaboration with Oxford University, we also did a systematic review on Noma, disease burden, but also treatment modality as well. Anyway, so I'm mentioning about several times, about the regional Noma control program, but we have aimed to sustainably eliminate Noma as a public health problem in African region. So, until last year, thanks to the support by Hilfsaktion, we supported 11 Noma priority country. I think Dr. Kodo is coming, she's from Senegal. But anyway, so we have mainly Western African country, but we also started to support Ethiopia from last year. And then this regional Noma control program is actually, we support country to focus on this, 7 points, which you see in this slide, such as enhance integration and coordinate and leadership of the national Noma control program, and also strengthen the capacity of the primary care worker for prevention and identification and treatment of early stage of Noma, and also build a capacity at the community level in oral health promotion and Noma prevention. And then the awareness raising and social mobilization campaign to improve public knowledge. But at the same time, as Petra emphasized that the Noma is really strongly linked with stigma. Therefore, social mobilization also quite important to reduce the stigma. And then, of course, health system strengthening is quite important, because if we only work silo, that is quite challenging to sustainable. Therefore, health system strengthening including the integration of Noma into the existing health system, including the surveillance system. We also, encourage country, and also we also encourage a country to contribute to the reintegration of Noma survivor and their family into the society. So I'm very, congratulate with Hilfsaktion's effort related to the, great achievement in terms of the integration of Noma survivor and their family into the society. And of course, improve the monitoring, evaluation, and research. We also, encourage our, country to do so. And then I just put some, achievements related training or action plan or surveillance, which maybe we can, slightly, quantified. So global online training, thanks to the global community, I think, more than 6,000, people joined this online Noma training course as of today. And then beside this global online training, as mentioned, that we supported by Hilfsaktion financially to support the 11 Noma operating country. As a part of this, support, each country also conducted the healthcare worker training. And then last year, around 4,300 healthcare worker was trained. Either, co-delivered by WHO or partner. And then in 2022, I think 4 countries actually developed the Noma action plan. And then in terms of surveillance system, for example, DRC Congo integrated Noma into the DHIS surveillance and also Nutrition Sentinel, because Nutrition Sentinel also monitor the malnutrition. As you know, that the Noma is also linked with the malnutrition. And also Burkina Faso is actually categorized Noma as a weekly notified disease. And also in Nigeria, Nigeria government also tried to integrate Noma into the real-time surveillance system as a SOMAS. Then now I also like to talk about integration of Noma into the WHO NTDs list, and then next step. So as I mentioned that, kind of like a tipping point, or I don't know how to say in English, but anyway, so in terms of the integration of Noma into the WHO NTD list, actually there is many campaign was happened, but at the same time, from WHO side, I also like to highlight one issue related to resolution on oral health. My previous slide, I mentioned some of the strategic achievements through all the chronological action. But in terms of the resolution on oral health, so this resolution actually included member states' request to WHO, to the Director General related to oral health. And then there are 5 requests, including please develop that global strategy on oral disease, and then the action plan, and also technical guidance, and then cost effectiveness intervention. But the final request is actually include Noma in the planned WHO 2023 review process to consider the classification of additional disease within the roadmap for NTD roadmap. But the why, integration of Noma into NTD, because as you know that risk factor for Noma are really common to the NTD, and then they often exist where Noma is found, poor developing country in Africa and Asia, but it also occurs whenever the risk factor exists, such as poverty or sanitation issue. And then the public intervention, such as individual or intensified case management or water and then hygiene sanitation, result in, both NTD, previous, 20 NTD, and also Noma, and then disease sequel. And also integration of Noma into NTD will raise its profile and then bring needed attention by National Health Authority or a specialized research institution and international development and a health agency. And then as all of you know that, after the submission of the request by Nigeria with support of the 32 countries, actually this is among 32 countries, 14 countries are actually African country. But anyway, after this request, from Nigeria plus 32 countries to the WHO expert group. The expert group actually recognized that Noma as a part of NTD, and then WHO officially recognized Noma as one of the NTD on 15 December last year. Anyway, so we are not, finished after just integration. We need to work more after this integration. So definitely the next step is integration of Noma into the NTD roadmap. I don't know whether you read the NTD roadmap or not, but if you go through the roadmap, close to the end of the roadmap, you can see that each disease, currently each, 20 disease, profile, and then the including target, or like assessment situation by technical progress, strategy and service delivery, and enabler and required action. Therefore, considering such perspective, global level, they need to consider, integrate Noma into this NTD roadmap. Before I will talk about what we need to regional level, because as mentioned that I'm working in WHO regional office for Africa. We mainly support the 47, member states in African region. But before that, I also would like to highlight some of the key results based on the systematic review related to the disease burden and also treatment modality, which jointly conducted by WHO headquarters and also University of Oxford, funding supported by Hilfsaktion. So key finding, you can see the left side of this slide, and recommendation, you can see the right side of this slide. And then this recommendation, we try to categorize. Red one is more tailored for the research or academia, and then blue one is more tailored for the Ministry of Health focal point. But anyway, first key finding is, as you know that, paucity of information. Sorry, I go to the next slide, sorry. So the first key finding is actually paucity of information and limited reporting on the microbiology of Noma. Therefore, recommendation for academia is actually urgent demand for basic science research on microbiology, pathophysiology, pathovirology, histopathologic feature of Noma, and also more detailed reporting of the culture technique and methodology for identifying the microorganism. The second key finding is intervention during the acute necrotizing gingiva stage lead to good outcome. And then the second one is currently no robust clinical study assessing efficacy of preventive intervention. So recommendation for the Ministry of Health is a program and strategy should increase disease knowledge and early diagnosis to prevent more severe stage progression. For the recommendation for academia is future research, including controlling cohort study to gain greater evidence in support of recommended preventive intervention. And then another recommendation for Ministry of Health is utilizing existing health infrastructure, cross-cutting initiative or routine assessment for the collecting of Noma epidemiological data and awareness and education. And then another key finding is a very few high-quality studies which assess treatment modality for Noma and also large heterogeneity in the treatment and outcome measure to assess most effective antibiotic treatment protocols. As you know that if you go back to the 2017 WHO information brochure on Noma, we also mentioning about the antibiotic treatment, but at the same time, with outcome measure necessary to assess most effective antibiotic treatment protocol based on this systematic review. Therefore, recommendation for the researcher would be future research should look to more robust study design and enrolling larger number of patients, clearly report and analyze treatment by stage of Noma, and also development of the standard case report form may support prospective data correction conducted to meta-analysis across different research study. And then another point is population bias and study design bias with, expert assuming, less than 30% of Noma patients would reach a care center. Because, this is coming from the, 1998, WHO global consultation of Noma. Because during the Delphi methodology, expert concluded that, experts assume that less than 30% of Noma's patients would reach a care center. Based on that information, disease burden was estimated at that time. But anyway, so in order to improve the current situation, recommendation for the Ministry of Health was community-based surveillance to describe the mortality rate of Noma is needed. And then another key finding is, as you know, that Noma is not only prevalent in the Noma belt region. This is also what I say, validated by our systematic review. Therefore, recommendation is a greater surveillance and a well-designed epidemiological study conduct globally, and also education and awareness effort on Noma, particularly training of the primary care worker and community actor beyond high-risk country. Oh, sorry, I still continue this slide. Then another key finding is the large variation across the few reported Noma burden of disease. Because I think the Elise is a specialist, but I think most reported countries, Niger or Nigeria, but we also need to get more information from different countries, therefore improve the understanding of global distribution and burden of Noma with more robust population-based epidemiological study beyond the Noma belt. It also consider promoting systematic reporting at the national level, not only integrated Noma into the passive surveillance. As mentioned that, already some countries started to integrate Noma into the DHIS too, but at the same time, active case surveillance, especially the early stage of Noma, that is critical as like an integration of Noma into the, during the mass drug administration of other NTD, that kind of active case surveillance is critical. And then another key finding is the definition and a stage of Noma progression, poorly standardized and reported across the literature. So, through this systematic review, the report, based on that, literature, the definition of a Noma is, different. Therefore, standardization also quite important, of course, in order to, improve the quality of the data and also, improve that estimation of Noma case number, etc. Therefore, great awareness of the WHO5 key stage of Noma disease and use these criteria in both case definition and reporting is also important. And then the final key finding is substantial heterogeneity in the risk factor reported to precede Noma. Because we realize that there is so many potential risk factors reported, but because of the substantial heterogeneity, we cannot say that this is a risk factor. Therefore, for the academia's recommendation is a risk factor and patient comorbidity should be corrected and reported at the individual level. And a new study design with a statistically robust examination of a risk factor and a method to adjust for the co-founder needed. And also discussion within the Noma research community on reporting guideline is advised to encourage standardization and inclusion of detailed, often omitted in the prospective publication. I hope you can understand my pronunciation. Anyway, so this is, final slide based on this, integration of Noma happened, and also that the result of the systematic review, conducted by Oxford, and then the WHO finished. And then we have some, what I say, future perspective, what we need to do at the regional level. But anyway, so definitely it is also quite important because silo approach is not so much cost effective. Then we now integrate Noma as a part of the NTD. Therefore, considering this situation, we also need to provide a strategic guidance and a technical support to country to integrate and implement Noma control effort as part of the national NTD master plan, especially in the African country, the country have a national NTD master plan. Therefore, integration of this Noma into the NTD master plan is quite critical to take more integrated approach with previous 20 NTD and also new NTD as Noma. And then, of course, need to improve surveillance. As mentioned, that it is important to integrate Noma as a part of the existing surveillance system, but at the same time, active case surveillance is also critical, utilize innovative technology. Then, of course, as like this, Noma network, which established by Elise and John and other colleagues, this kind of strengths and expansion of existing network and community of Noma is also quite important to leverage our knowledge and experience together in order to accelerate the tackling of Noma. And also, definitely, even the still Noma integrated into the NTD, still many people not know about the Noma. Therefore, definitely, we need to strengthen communication and advocacy strategy to integrate Noma into the NTD brand. While because basically currently or before integration Noma, oral health program is working on Noma because Noma started from mouse, but at the same time we need to work together with NTD community and oral health community and also other actors such as nutrition or vaccination or NTD actor in order to more raise awareness on the Noma. And also, of course, build the capacity of Noma and oral health and NTD focal point and other professionals to help prevent, identify, and treat Noma. And also, as mentioned, that the integration of Noma into NTD potentially, improve the visibility of Noma. But at the same time, this will not, come sooner. Therefore, we also need to, really take effort for the mobilized resource to support country in accelerating Noma control efforts. So that's all my presentation. I hope you can understand my presentation. Thank you very much. Over to you, John.
Thank you very much, Yuka. That was absolutely terrific. I do want to steal a question before we open it up to the rest of the network. I was hoping to hear from you about what the WHO is doing. You spoke to Noma's integration into the NTD roadmap. How has that been balanced, I guess, with also trying to integrate Noma into the Global Oral Health Action Plan for 2023-2030? How are that integration process into both of those roadmaps been?
So thank you very much. So I just would like to introduce, because some of you is a more NTD group, therefore maybe you are not familiar with the oral health group. Therefore, I also would like to inform about the Global Oral Health Action Plan. So as mentioned that in the WHO resolution on oral health in 2021, member states, country request WHO to do some action related to oral health. One is actually integration Noma, but other three is linked to this, Global Oral Health Action Plan. But anyway, so first is, please develop the oral health strategy we developed. And then the second point is, in order to implement this global strategy at the country level, please kindly develop the, Global Oral Health Action Plan. And then this Global Oral Health Action Plan also endorsed by WHO member states in 2023. So this Global Oral Health Action Plan is actually consisted of the 11 global targets, and then also include the 100 recommendation action for member states, WHO international partner, in order to achieve these 11 global targets in line with the strategic area of the global strategy, such as governance, and also the promotion and prevention of oral disease, and also oral health care, and also the oral health workforce, and also the information, surveillance, and also research. And then if you see some of the information, for example, the governance, you can see the Noma, that is actually that if country is affected Noma, consider to develop the National Noma Action Plan. And then the research part, you can also see that we need to strengthen Noma research and also correct the Noma research into that online sharing network or something. Therefore, if you see this Global Oral Health Action Plan, you can also see some of the recommended action related to Noma.
Awesome. Thank you very much. Are there any other questions for Yuka? Please also feel free to put them in the chat, and I'm happy to read them aloud. Yes, Maisa?
Hi. Is it Latifa? Okay. Is it me or Latifa?
No, go ahead. No problem.
Please go ahead. Please.
Yes, hello. Yeah, I'm in my office. So I took a break to listen to this very interesting conference. Thank you. I'm thinking about microbiology of Noma. Are there studies about the oral microbiome, involving not only bacteria, but we know there are candida species and even parasites. And we know that people also are exposed to other diseases, malaria, HIV, etc. How to find the way to understand the interaction between what happens in the oral microbiome and other infectious diseases that affect the person affected by Noma. You know, he may have malaria, he may have HIV, probably at an 8th stage. So do you think it will be possible to study this interplay, these links between what happened in the oral cavity and infectious diseases, all infectious diseases? Thank you.
Thank you very much. I will comment based on our result of the systematic review, but in case Elise, if you also would like to add anything, please feel free to add. But anyway, so based on the systematic review which we conducted, I mean, like we actually finally review, I think, I mean, around 350 paper in our systematic review. I mean, after what I say, I mean, all the, what I say, selecting criteria satisfied, we reviewed around 300 paper. But anyway, based on this, I mean, selected paper, we identified more than 100 bacteria is actually detected, I mean, Noma patients. Therefore, we could not conclude, I mean, what kind of like bacteria actually, I mean, trigger the cause of Noma. And then we also wondering potentially maybe that's the opportunistic infection rather than, I mean, the potential, I mean, specific bacteria. But as mentioned that in terms of the, I mean, microbiology of Noma, the paucity of information and the limited reporting on the microbiology of Noma. Therefore, we cannot conclude whether this is opportunistic infection or some specific, I mean, microbiology trigger. That is, I mean, the current situation. Therefore, as mentioned during my presentation, one of the recommendations for the, I mean, academia is actually urgent demand for the basic science research on microbiology, pathophysiology, and pathology, I mean, future of Noma, and also more detailed reporting of the culture technique and methodology for identifying microorganisms. So that is, I mean, our, I mean, recommendation based on that systematic review. But in case it is, if you want to add anything, please feel free to, over to you.
Thank you.
I think exactly,
okay,
yeah, what you said was right. And you know, there are two groups that I know of. Oh, Mark's actually online. I was going to mention Mark could maybe give you a bit more information about their study into the microbiology on Noma. We did have a presentation on which I think John's actually just posted. I see the link to that webinar, our 4th webinar. But Mark, maybe you could give a little introduction to your study. And then there is another group also working on the microbiology of Noma. So it's definitely something on the radar. And yeah, definitely something that needs a lot of work. Mark, are you still on the line?
Yeah. Yes. Can you hear me?
Mm-hmm.
Can you hear me?
Yes, it's okay.
Yeah, great, fantastic, good. Yeah, thank you. Yes, I've been sitting quietly in the background. Thank you for both the presentations. They're both really great. I was going to ask you a question around this actually, Yuka, but if I just say what we're doing, we have been able to work with some guys locally at Sokoto to collect samples. And they are literally on their way right now to us. I haven't checked with Josh recently, but I think they should either have arrived yesterday or they should be arriving this week. And we'll have samples from matched cases, gingivitis cases and controls, hopefully. And we'll be able to start doing some metagenomics and things around various aspects. So that's something we might be able to start, to answer some of these questions. And Josh is going to be starting on the DNA extraction very soon on those. So that will be great. What I was going to ask you, you mentioned that you said there's like a variation in risk factors. So do you think that means there's a variation in microbiome as well? Or do you think all of the variation in risk factors has the same impact on changing the host response?
You mean that whether that I say that variation of risk factor, therefore whether we also have a variation of the microorganism or not? Yeah,
because I mean, when we talk about necrotizing gingivitis in a sort of a Western population, or I guess a Japanese population, you would say, oh, it's classical necrotizing disease, isn't it? And there's a whole thing around what's the difference between that and what's going on here. or is there a difference? Is it just a bigger version of the same thing? Having seen a few, there have been cases reported in Europe, and as you said, and I've seen a patient who has lesions developing on their buccal mucosa, even though they had diseases in their gums. It's just interesting as to where all of those things go. I'm just curious what you think.
Yeah, I mean, this is very difficult to answer, but as mentioned, I don't know, I mean, because you maybe sometimes disconnected, but based on this systematic review, I mean, in the end, we reviewed around 300 paper. I mean, that is what I say satisfied criteria. In the end, I mean, more than 100 microorganisms was identified with Noma patients. Therefore, we did not do the further what I say analysis depend on the which area have a more, I mean, this specific, I mean, bacteria or that area. But I mean, potentially we also have a, I mean, geographically variation, or I mean, that's the time variation, or, but we did not do the further analysis, but at the same time, also that quality of the paper which was included in this systematic review was also not so, I mean, high. Therefore, we don't know whether we can do the further analysis related to specifically focus on the microorganism. I hope I responded to your question.
Thank you.
Oh, Promise, would you like to ask your question, please? Can you hear us?
Thank you very much. Can you hear me?
Yes.
Yes, apologies for the background noise, if any. I really thank the presenters for their wonderful presentation. Actually, I just want to make a remark that I've been in line with the pattern of the studies that they are doing, and I really appreciate that. I wanted to use the opportunity because I'm kind of running out of time to also make a remark on my own work that I'm actually soliciting assistance for. Like I'm currently working on a kind of a management protocol for Noma patients within the Noma belt per se. That's according to the ethical approval that was received, that we've obtained. So I would be needing a kind of assistance from each and every one of us to be able to finalize the process of data collection for the patterns of management of Noma patients. So we are soliciting for the experts review, for the experts response, those experts in the sense of surgeons, administrators, nurses, and nutritionists, and the psychologists, people that are involved with the management of Noma patients. So I just wanted to highlight the need for a collaboration and an assistance towards
Promise, I'm sorry, I think we might have lost your audio. If you'd like to write in the chat, if you'd still like to add something, I can read that aloud.
Sorry, did you get my point?
We heard the majority of it. We lost you for 20 seconds or so. Sorry.
Hello?
Yes, we can hear you.
Okay, did you get my point, please?
Yes, we did. We missed the last
Thank
few
you.
seconds, but I think we got the majority of it.
Okay, thank you very much. So I will be also communicating with Ellis for further protocol and take it up from. Thank you.
Terrific. Thank you very much. Maisa, did you still have a comment or question you'd like to make?
Yes, I have actually had a similar question like Mark, because I thought also like we have the necrotizing, like ulcerative gingivitis. What happens then? And if there, Yuka, thank you so much for the whole work also and your presentation. If you have in the future a plan to make the risk factors more specific, it's clear that one of the main risk factors is exposed to extreme poverty, but also extreme poverty comes, this frame comes with it many risk factors. You've already mentioned WASH, or being exposed to like a viral infection, which is preventable, like preventable diseases like measles. And if this could be playing some role in the microbiome and causing such complex results. And also I wanted to ask you, because I was really interested, have you had discussion in the WHO regarding putting Noma within the oral health sector and materials, or it has been always affiliated to the NTDs? Yeah, thank you.
So thank you very much. So, I mean, as like a microorganism, the risk factor, I hope you can hear me. Yes. I mean, risk factor also, there's so many risk factor identified. But I mean, most of the report, I think, I mean, I cannot remember actually how many percentage of the paper is actually case report. Therefore, quite difficult to define the, I mean, risk factor based on the available, I mean, study. I just would like to highlight its point. Then in terms of the either oral health or NTD, because initially, I mean, as mentioned that around 1994, I mean, Noma started to work with, I mean, oral health, because, I mean, Noma started from oral health. But, I mean, after that, I mean, NTD concept is evolved. Then the, I mean, some, I mean, the stakeholders think, because this packaging of the NTD would be more, what I say, I mean, potentially raise awareness. Therefore, I mean, this, I mean, NTD concept is evolved. And then I think, I mean, around the mid, I mean, 2010s, I mean, around, I mean, 2010 year, around 2010 to 2019, some of what I say, movement happened related to the integration of Noma into NTD. But anyway, so I mean, definitely it is quite important to work with both, I mean, NTD and oral health, because as mentioned that Noma starts from oral health. Therefore, definitely oral health community, the, I mean, person who can detect Noma, I mean, initially potentially, but at the same time, Noma is now integrated in NTD because, I mean, the characteristic is similar. Therefore, if we can take the integrated approach with other NTD, that is also potentially effective. Therefore, definitely, I mean, we cannot say, I mean, we need to definitely go Noma oral health or go Noma oral, I mean, NTD. And then, for example, because after this integration, I mean, WHO headquarters is going to recruit a consultant based in both NTD and the NCD department. Therefore, our point is definitely need to jointly work together with NTD and NCD, because oral health is under NCD. But at the same time, it's definitely not only these two departments, we of course need to work with nutrition and also vaccination, and also, I mean, maternal child health. Therefore, we cannot say we need to take lead, I mean, only one department. Definitely, I mean, because collaboration activity is important. And also because Noma is beyond the health. Therefore, definitely multi-sectorial approach is critical to tackle this disease. I hope I can answer your question. And then Petra maybe raise or comment or, I mean, provide a supporting idea, or over to you, Petra.
Oh, Petra, I believe you're muted.
Now? Better. Yeah, thank you so much, Yuka, for your comment. And I would definitely second your comment that, you know, we have a pretty clear idea about the risk factors of Noma. And it really comes down to a bad condition of the immune system in small children, where the immune system is already, you know, not as far developed as in adults. And if further factors like an HIV infection or other diseases like malaria or tuberculosis or measles come into place, plus malnutrition at sometimes extreme, you know, in extreme measures, If that's the case, then the risk of contracting Noma is significantly higher than with healthy children. And I think it was in one of the earliest studies that took a look into Noma back in the 1980s, I think, where people have taken a look into why did it get eradicated in Europe? And it said that Noma vanished in Europe when even the poorest child in Europe had access to food. So food is crucial. And I don't want to polarize, and I know that finding the exact microbe that might cause Noma is always, it's like the holy grail for epidemiologists. But from a practitioner's point of view, I would say for an organization like ours, it doesn't even make a difference, because you see a Noma child in early stages, you give antibiotics, you know that they work. It doesn't even matter which, if it's a fusobacillum or another culprit. So I think the main target should actually be address the unfairness of distribution and address the unfairness of poverty and hunger, and that's gonna be the way to address Noma. Yeah, thank you.
Yes, Yuka, would you like to say something?
Yeah, thank you very much, Petra, highlighting this, comment. This is, really, really important point. And then as mentioned that, our systematic review identified more than 100, microorganisms, and then potentially that Noma would be potentially opportunistic infection. We cannot confirm anything yet because of the quality of the evidence. But at the same time, one point I also would like to emphasize is, compare, of course, the Noma is more social or potentially that's beyond health disease. But at the same time, Noma, we don't have a point of care diagnosis. Therefore, in case if we can also potentially identify some of the microorganisms which trigger the disease, the good point is we can also diagnosis without delay. Therefore, we also need to, of course, we need to both. Definitely we need to take action related to, a social mobilization, or improving that access to healthcare, and also the improving access to nutrition. But at the same time, some basic, research also quite important in order to, improve the diagnostic issue, and also a development of the point of care of diagnosis test. I just would like to, point out that point.
Thank you. Latifa also put a question into the chat. Do you think that Noma behaves like an autoimmune disease, or it involves an autoimmune component?
I cannot answer, but at the same time, because that, as you know, that immunosuppressed, or suppressed children, such as if they have some of the co-infection with measles, or malaria, also linked with. Therefore, we need to definitely have a more research related to how this disease is actually evolved, whether also linked with the ontology, the reaction, or this kind of things also needed to identify based on the research. But at this moment, we cannot say whether there is any reaction or not. But in case, if, because more researcher is knowledgeable about this perspective, therefore, in case Elise or any other researcher, if you'd like to add my comment, please feel free to add. Over to all of you.
Yes, Maisa, I think this, in the interest of time, respecting everyone's time, I think this will be our last question as well, but do please. Thank you.
Thank you, Jean. I just wanted to share an idea, because in epidemiology, they call the father of epidemiology John Snow, when he stopped the epidemic in first epidemic in London, he actually didn't know the causative organism back then for the cholera, and he did this map to identify like some kind of a surveillance to identify the affected area, and he just cut the mode of transmission. So I can imagine in Noma, it's not an infectious disease, but like also focusing on this risk factors that Yuka and Petra talked about, and meanwhile, in parallel, identifying the causative organism and for diagnosis is could be a pretty an approach. And also for surveillance, because Yuka, you mentioned about that some countries are implementing or integrating surveillance, and under this like some kind of mysterious circumstances of Noma, I think surveillance is a priority. And I wanted to ask you, have you saw the results of the surveillance from those countries? Are they able to identify the cases in a timely method? Of course, there are many challenges, but maybe you've seen like the first results from any of those systems who which implemented the surveillance for Noma. Just a brief for the time. Thank you so much.
Yep, thank you very much. Maybe I can share with you some example. For example, DRC Congo. We did not receive any report related to DRC Congo, but as mentioned, that DRC Congo tried to integrate Noma into the nutrition sentinel, because as we mentioned that the malnutrition and also, Noma reported the linkage. Therefore, through the, nutrition sentinel, they finally, reported around, of course, less than 10 cases, but I think 2022, they reported some Noma cases. Before that, they did not report anything, but they started to report some cases because after integration of Noma into the nutrition sentinel. And then one thing I also really look forward to listening or like learning from the Nigeria experience, because we also try to collect the information based on the facility-based information, such as primary care level or community level or even the hospital level. And then we encourage country not only share with us the information from the hospital-based level, but also primary care level. Then as mentioned that now Nigeria integrate Noma into the real-time surveillance system called SOMAS. And then SOMAS should also collect the information real-time in the primary care level. But there is some, what I say, the problem happened related to SOMAS. Therefore, they could not report us related to the primary care level data, but definitely they also, have some data from the primary care level. Therefore, we really look forward to having some information from the country, related to the Noma, especially from the primary care level. Then as mentioned that, DRC already, after introduction of the, Noma into the nutrition sentinel, they started to report. And then I know that Dr. Koro, Chief Dental Officer from Senegal, sees participates. Therefore, because we don't have a time, therefore we don't have a, we cannot like maybe ask Dr. Kodo, but she also can share her, what I say, impression about the integration of Noma into the existing surveillance system and how this work or support for that, improve the collecting the Noma data. Anyway, I hope my point is clear. Over to maybe John.
Thank you.
Yes, thank you very much. And I would like to reiterate my sincere thanks on the part of the International Noma Network, myself, Elise, and Stuart, for Petra and for your Yuka, your presentations today. Thank you very much. And thank you to all of you and the participants who joined this call today. And my favorite part of these webinars are the questions that come at the end, and that sense of community that we're trying to develop within the International Noma Network. So please do check out our website, and also stay tuned for our next monthly webinar, which will be at the same time next month, on the 30th of July, and that will be Dr. Bala, who, as I mentioned earlier, I believe in the chat, was the primary author on an article about Noma in twins, and he'll be talking about his research as well. So thank you all very, very much. Please do feel free to reach out to us at contact@the internationalnomanetwork.com, and you can check out our website as well. Thank you again, and thank you, Petra and Yuka, for your time. We will see you all soon. Bye-bye.
Bye, guys. Thank you so much.
Thank you very much. Bye-bye.
Thank you. Thank you very much.